Welcome back. In our last explainer, we figured out where all the water in our body actually is. But, that was just the map. Today, we're diving into the traffic, the incredible forces that push and pull fluid around every single second, and what happens when that traffic gets into a catastrophic jam. And this question right here, it's everything. This isn't just some textbook theory. Answering this is literally the key to understanding some of the most serious conditions in all of medicine. Think of it like a physiological mystery, and we're about to piece together all the clues. Because really, every single one of these, from swollen legs to a life-threatening drop in blood pressure, they're all, at their core, a story about fluid moving across a membrane and ending up exactly where it shouldn't be. If you can understand the forces, you can understand the disease. It's that simple. So to get there, we need to meet the two main characters in this whole drama. And I want you to think of it as a constant battle. This physiological tug of war that's happening inside every tiny capillary in your body, all day, every day. And here they are. In this corner, we have hydrostatic pressure, the force that pushes fluid out. And in the other corner, oncotic pressure, the force that pulls fluid back in. This fundamental opposition, this push and pull, is the engine that drives pretty much all fluid exchange between our blood and our tissues. All right, let's start with the pusher. Hydrostatic pressure is, well, it's just the physical pressure of the fluid itself. The absolute best way to picture this is like a leaky garden hose. The water pressure inside that hose is what forces water out through all the little tiny holes, right? In our bodies, that's just blood pressure pushing plasma out of our capillaries. And here's a number you got to know. Right at the beginning of a capillary, we call it the arterial end, that pushing force is sitting at about 35 millimeters of mercury. Go ahead and lock that number away in your brain. It's the big, dominant force at the start of this whole journey. So, what stops all our fluid from just leaking out into our tissues? That's where the puller comes in, oncotic pressure. It's a special kind of osmotic pressure that's created by big proteins, mostly one called albumin, that are just too large to escape the capillary. They act like these tiny little sponges, constantly pulling water back in and holding on to it. And here's its number. This pulling force is a pretty steady 25 millimeters of mercury all the way along the capillary. So you can already start to see the dynamic, right? You've got a strong push of 35 at the start, fighting against a constant pull of 25. Okay, so we've got this push and pull happening between our blood vessels and the space around our cells. But there's another absolutely critical fluid shift we need to talk about. And that's the water moving in and out of the cells themselves. This is governed by a totally related but distinct concept called tonicity. You see, while we can measure something called osmolality in the lab, what really matters at the bedside is tonicity. It's all about the functional consequence. It asks a really simple question. If I put a living cell into this fluid, what's going to happen to it? Is it going to swell up, shrink down, or stay the same? And this just lays it out perfectly. In a hypotonic solution, water floods into the cell and it swells up like a water balloon. But in a hypertonic solution, all that water gets sucked out, and the poor cell shrivels up like a raisin. It's only in an isotonic solution where the cell's perfectly happy and stable, with no net water movement. And here is where this becomes incredibly serious. Because sodium is the main driver of tonicity outside our cells, any problem with sodium is really a problem with water. And nowhere in the body is that more dangerous than in the brain. Think about it. The skull is a rigid, bony box. There's no room to expand, so any swelling or shrinking of brain cells from these water shifts leads directly to the confusion, the seizures, and even the coma we see in bad sodium disorders. Okay, so we've seen how tonicity affects water going in and out of the cells. Now let's zoom back out to the capillary and bring our original players, that push and pull, back to center stage. It's time to see how they all interact in this famous balancing act we call the Starling forces. Now, the full official equation actually looks at 4 forces. You've got the 2 big ones we've already talked about, the push out from inside the capillary and the pull in from those plasma proteins. But to be complete, you also have 2 much smaller forces in the surrounding tissue, a tiny push back in and an even tinier pull out from any proteins that have managed to escape. But let's be real, clinically, we can simplify this. Just think of it as that tug of war. All the forces pushing fluid out of the vessel, we call that filtration. And all the forces pulling fluid back in, that's reabsorption. As long as those 2 are more or less in balance, we're golden. The second filtration overpowers reabsorption, that's when you get edema. Now here's where it gets really, really interesting. It turns out that even if all those pressures are perfectly normal, there are two wild cards in the system that can come in and just completely change the rules of the game, causing massive fluid shifts. Wildcard number one is the wall of the capillary itself. In something like sepsis or a major burn, inflammatory chemicals basically poke holes in the vessel walls, making them super leaky. Now, those big protein sponges, the ones that were supposed to stay inside and pull water in, they can escape. This absolutely tanks your pull-in force, and at the same time, it creates a brand new pull-out force, leading to a huge sudden rush of fluid into the tissue. The second wild card is our body's safety valve, the lymphatic system. You see, a little bit of fluid and protein is always leaking out, and it's the lymphatic system's job to act like a vacuum cleaner, sucking it all up and returning it to the circulation. But what happens if that system gets blocked, say from a surgery or an infection? Well, the drain gets clogged. The fluid has nowhere to go, it backs up, and you end up with a very specific protein-rich type of swelling called lymphedema. Okay, this is it. This is the moment where everything we've talked about comes together. We've built this entire framework of pressures and wildcards, and now we can use it like a detective to diagnose the real root cause of edema. This is the clinical payoff, where all that physiology becomes real-world practice. And this table right here is incredibly high yield. Just look at how each condition maps perfectly to a specific failure. In heart failure, it's a plumbing problem, a backup that increases the pushing hydrostatic pressure. In liver failure, the body can't make enough albumin, so the pulling oncotic pressure just plummets. With inflammation, like in sepsis, the problem is leaky pipes, increased permeability. And with lymphedema, it's a blocked drain. It's the same result, edema, but for 4 completely different reasons. This all brings us to what I think is the single most important takeaway from this entire explainer. I really want you to burn the sentence into your brain. Edema is not about having too much water in the body. It's about having fluid, maybe even a normal amount, that has moved into the wrong space. And why does that matter so much? Because it changes everything about how you approach a patient. Your goal isn't just to blindly pull off water. The goal is to figure out why the fluid is in the wrong compartment and fix that underlying pressure imbalance. Once you get that, fluid therapy starts to make perfect, logical sense. So, let's do a quick recap. We have journeyed all the way from the basic push and pull of fluids to understanding precisely how different diseases hijack this system to cause edema. And we've seen why things like sodium and albumin levels are so unbelievably important to watch. Which, of course, leaves us with one last fascinating question. The body doesn't just sit back and let this happen. It has sensors, it knows when things are wrong. But how does it know, and what does it do to fight back? Well, answering that is going to be our focus next time, as we dive into the amazing hormonal systems that regulate this whole balancing act.